Pancreatic fistula are one of the main problems in pancreatic surgery, and one of the main causes of death after pancreatic surgery. What is? We heard a very long presentation about what is. It is an abnormal communication between the pancreatic ductal epithelium and another epithelial surface containing pancreas-derived enzyme-rich fluid. Unfortunately, the tract is not a straight tract, but frequently those communicating with access cavities. We heard about the four definitions with the variability of the incidence of pancreatic fistula with a severe or with a more less severe definition. But at the end of the history, we heard that the output via an operatively placed drain or subsequently placed percutaneous drain of any measurable volume of drain fluid on or after postoperative day 3 with an amylase content greater than 3 times is the definition of pancreatic fistula. We heard also that there is a main grading of pancreatic fistula, but we can see that the main difference between B and C pancreatic fistula is the reoperation and sepsis. But both conditions are dependent on how you deal with the patient after the procedure. You can remove early your pancreatic drains when you have no sign of fistula, but you have to consider to do something to drain better to avoid sepsis, to prevent sepsis and to prevent surgery. Now, the incidence of pancreatic fistula is very different. This is a series between 1999 and 2004, but not only the incidence of pancreatic fistula is different, it's different also the reoperation rate between 6.2 to 23.5. It is different the completion pancreatectomy from 0 to 7%. It is different the mortality from 0 to 12%, the mortality from pancreatic fistula. This is another series, 5 years again, from 2005 and 2008. And again, the pancreatic fistula rate is very different between the different authors, from 7.3 to 32%. The reoperation rate reached 65.8% or 0% in other series. The completion pancreatectomy, 9% or 0%. The mortality, 0 or 22%. Last year, I published 4 series. We published our series on 445 patients with a fistula rate that finally was similar between among the 4 groups, from 12.9 to 17.4. There is no great difference, but only one of this group applied IS-GBF criteria. All the other I included were unable to apply IS-GBF criteria. The reoperation rate, as you can see, varies also between 4.2 to 16.5. The completion pancreatectomy also is 0, not reported, or 6, and the mortality varies from 0 in our series to 14%. Now, we define the pancreatic fistula according to Mayo Clinic criteria because we started reviewing patients since 1993, and we are unable to apply ISTBF criteria. But our policy with pancreatic fistula was as follows. In presence with clear fluid with normal amylase content, surgical drains are removed within 5 to 10 days. Whenever an amylase rich or unclear fluid, the drains are replaced, usually between the 7th and the 8th postoperative day because the tract is solid enough, with angiographic catheters by an interventional radiologist. One of the catheters is inserted as soon as possible through the fistula within the bowel. If an undrained perianostomotic lesion is detected, it is drained via a percutaneous approach. Aim of the procedure is to create a straight external fistula, to transform a type B, type C in type A pancreatic fistula, without stagnation of pancreatic juice along the fistula tract. 49 patients underwent drain substitution. 16 patients underwent percutaneous drainage, and 2 patients underwent both percutaneous and drain substitution. But you can see that only 3 patients underwent surgical treatment. And the 3 surgical procedures are as follows. One was in 1993 in the first patient we treated with the duodenum-preserving pancreatic catheterization for benign pancreatic disease of the head of the pancreas. And this was the worst result because he underwent 3 surgical procedures. The second patient underwent an emergency surgery after an uneventful course for 7 days. Then, after peritonitis, we opened the patient, drained and cleared the abdominal cavity, but we put the drains in the same way as we do when we don't operate the patient. The third patient was only treated with local anesthesia to separate a colonic fistula from a pancreatic fistula. So the abdomen was not open. Since 1st September 2007, further 31 postoperative pancreatic fistula were diagnosed. So 101 pancreatic fistula were seen until now, with all treated conservatively but one, and the one was operated because a patient with chronic pancreatitis operated in 1981 had problem with a pancreatic jejunostomy. It was remade during surgery, but the jejunal loop underwent necrosis. So we needed to resect the necrotic jejunal loop and to perform another anastomosis. The reoperation rate overall was 4%, and the mortality rate was 0%. An example, some example, here you can see a fistulogram showing multiple collection in the bowel anastomosis to the pancreas. Here you can see the drain. It was still a tubular drain. This is an old slide. The drain was changed with angiographic catheters. One was put within the bowel, the other outside the bowel, and the fistula closed. This is another patient. Here you can see the drain left during the operation with irregular collection. We put some drains within the fluid collection, but without results, until we put a drain through the hole within the bowel and the fistula closed. Our post-operative mortality in this 445 patients was 3%, 14 patients died, 3 of myocardial infarction, 1 of pneumonia, bilateral pneumonia, 1 of cardiac tamponade in intensive care unit, I don't understand why, 1 of massive embolism, 7 hemorrhagic shock, no one related to pancreatic fistula, and 1 for liver failure. Post-operative hospital stay was longer, obviously, after pancreatic fistula, you can see, but not so longer. So, we may decrease the incidence of post-operative pancreatic fistula thanks to a careful technique. But unfortunately, we can't eliminate the problem. It is therefore important to manage aggressively with the aid of an interventional radiologist any patient at risk of developing a post-operative pancreatic fistula to prevent stagnation and subsequent invasion of eventually activated pancreatic juice. By this way, we can decrease the mortality rate and the percentage of the operation. Thank you very much for your attention.